This is the C-Section Experience podcast, where we support you in preparing for and processing your C-section journey through education, validation, and storytelling. We're here to reduce anxiety, amplify your voice, and help you feel truly seen. I'm Dr. Jen, an obstetric anesthesiologist.
And I'm Bethany, a nurse and a birth educator. As friends and fellow C-section mamas, we're on a mission to empower you. Through personal stories and expert guests, we'll laugh, we'll cry, feel all the feels, so you can approach your birth with confidence. Are you ready? Hi, Jen.
Hi, Bethany.
How are you today?
Good. I'm excited for our topic. It is very up my alley.
It is your alley, Jen.
It is my alley today.
It's your whole map.
It's my whole everything.
Yes.
So we are going to be talking about anesthesia consults.
Mm-hmm.
So what they are, when to request one, how to request one, everything that everyone should know about anesthesia consults, because I think it's something that's really not well understood.
Totally.
I've been hearing recently that some people don't even know it's possible. And this is how we kind of get ideas when a bunch of things collide at once. We had received an email from a lovely listener of Katie. So shout out to Katie. Thank you so much for reaching out to us. And she mentioned that she was a nurse and she didn't even realize that this was something that was possible, that she could request to talk to anesthesia. And then I was also listening to the Birth Trauma Mama podcast. She did kind of a double episode where the first one she talked to Dr. Heather Nixon, who was one of the OB anesthesiologists who is profiled in the Retrievals podcast. And then she had a discussion afterwards she co-hosted with, I think she's another
Therapist,
social worker. And they also mentioned that one of them didn't realize that was something that patients are offered, that they can actually talk to an anesthesiologist. And for me, this is one of my favorite things to do. I love anesthesia consults. In a perfect world, I actually think everyone should speak to an anesthesiologist before they give birth, no matter which way. Another thing they brought up in their conversation was that anesthesiologists really are hospital physicians. So to go even more specific, intraoperative. So we're taking care of you generally in an operating room, and we don't get a lot of time with patients either before that experience or after that experience to see how what we did for them in the OR may translate into recovery, into any long-term consequences, because we just definitely don't see people again. We might see them, we've talked about this, in the recovery room or maybe the next day after a C-section, but we just don't get that long-term care.
I love that they brought that up too, because it feels like a piece of the puzzle. One of the biggest pieces of the puzzle of your surgery is your anesthesiologist, and how it is so comforting to have that doctor come back into the room and do that little check-in.
Yeah, and imagine if you even knew them already.
I know.
That's like the ideal perfect situation.
And on the other side, you knowing them in a more in-depth way so that you can, I think that you pick up on people's personalities pretty quickly, and I'm sure that's part of where you're really good at your job as well. And if you see someone nervous ahead of time and then they get through the surgery successfully, and then you can see them again and validate their feelings of being, I know you were so nervous coming in, but how do you feel now? And how that personalizes somebody's experience of you validating that initial emotion that you saw them.
Yeah, so
feeling.
Even better if we can have these conversations even further ahead of time. That makes the patient more prepared. That also allows us to be more prepared when the patient does come in for delivery. I just think that's the perfect model of care, is having some contact before, obviously everything that we do during the whole delivery process, and then having contact again afterwards. And that really is not only beneficial also for the patient to be able to ask any of their questions and maybe be flagged by a physician to say that, there's something that we can do even now for you. There's something that you're not handling as well as you could be, and et cetera, et cetera. But then it would help us too as anesthesiologists to tailor our practice and look back and say, what was it that we can now work on so that we can reduce the chances of these types of things lingering or causing problems later on.
Yeah.
So I have a list of conditions, let's say, that oftentimes the anesthesiology department will tell the obstetricians, these are the things that if a patient comes in to your office with any of these conditions, please send them for an anesthesia consult.
Okay. So your OB is going to be the one who's going to facilitate.
Yeah, so this is where the anesthesiologist is kind of requesting the consult via the OB. The other way to do it would be is if you as the patient say, either you recognize some of these things in yourself and maybe it was missed or they have a different list wherever you are. And then you can say, I want to see an anesthesiologist ahead of time because XYZ, whatever. And the timing of these consults, it really depends on the condition, but usually let's say late second trimester, early third trimester would be a good time to have this discussion with your anesthesiologist. It could be earlier if you think there's a reason you may be delivering earlier, but that's a good time to have enough of a chance if, let's say, sometimes we might say order a test or I want some report from some specialist that you see, something that you can then have time to gather that and bring that in with you when you have your delivery. And time for us, too, to make a plan and time for you to start feeling just basically
Supported.
more prepared and supported and less stress on, I have to relay all this information as soon as I get there. And I always recommend, repeat. Tell your OB, tell your anesthesiologist, tell your nurse when you walk into the hospital. If there's something that's really concerning to you, you just never know. Just repeating it all the time is fine. That's why we repeat important things to you as the patient and ask you 100 times if you have any allergies or anything that we know is significant. We're going to ask you again because we want to hear it from you. So same other way around, I guess.
I can also just say I think there's a calming factor as a patient when you say something a couple times and you know that you've touched on all the different people who might be taking care of you. It's like, I let everybody know. I mean, that's how I felt. I felt that I felt calmer communicating my concerns to everybody.
Yeah. And so I'm going to go through the medical conditions first. And then at the end, I think when we talk about reasons that patients can and should request an anesthesia consult, you can help me think of other ideas.
I
think you'll be able to.
I think so too.
Another thing about just before we begin with this list, how the anesthesia consult works pre-COVID, a lot of places probably did these in person. So there's sometimes a clinic that you can go to. Sometimes it means going on to labor and delivery and there's them finding a room to have a discussion with you. Many times that's not really necessary unless there's something that they really need to look on your body to see if they can guess if this may cause an issue or not. So that could be, there's sometimes a reason to go in, but most of the time this can really be done virtually or just with a phone call. And of course, since the pandemic, we kind of realized that. And I think it's just easier for the patients to comply or easier for everybody, right? Get on a phone call than wait for, the way we used to do it back when is, you get a call that somebody's in and then you tell them to come at a certain time. But of course, you can never predict that at 2:00, you're going to be free. And what happens is at 2:00, you're busy and then they're waiting and, it becomes kind of a whole thing. So I definitely think most of the time it's just easier for both patient and provider to just have a phone call. And then maybe, let's say, after the phone call, you have identified a reason to come in, then you can kind of jump through the hoops a little bit more with that one. But
can I back you up a little bit? Since you started your practice, has it always been getting an anesthesia consult is a possibility, or is this like a newer concept?
No, it's always been a possibility.
Okay.
I think it's usually more established at a larger institution.
Okay.
Where we might even have a clinic for like a specific area that's literally just the pre-anesthesia clinic that people might staff. So like they're just there and they might be coming in for other surgeries as well because this is not the only surgery that it's relevant to see an anesthesiologist ahead of time. So a bigger place might have like a full system set up for that, and a smaller place, just staffing, et cetera, et cetera. It might be more of that, let's see who's available to talk to you, depending on what time you're coming in.
I guess why I'm asking it too, it's like, would a patient feel like this is a big request? Is this like it?
No.
Right. Okay.
Yeah, no,
this could be a common request.
Yeah, it doesn't end up being that common. I kind of want to make it more common. And if anyone has ever been denied an anesthesia consult, please let me know because I'd be very curious to hear that. But as far as I know, that's not a thing. It might be difficult to schedule, which is why I would say if this is difficult to schedule, can I leave my phone number and have someone call me back in the next few days, whatever it is. So tends to be how I've done it recently, where I'm not guaranteeing a phone call at a certain time, but I'm trying a patient, and if they're not there, I'll leave a message, tell them I'll call them back tomorrow at a certain time, whatever it is. And it's just not too difficult, I guess, to manage. But this isn't an emergency thing, right? It's not like you need a call back from your OB because you're worried about something going on with you right this second. It's more of
it's a preparation thing.
Yeah.
Yes.
It's like this is like in the next few weeks almost we can get this done.
Yeah.
And so it's just finding the time to do that.
Got it.
Okay, so this is a list that I've seen being submitted to OB departments of reasons why the OBs should actually make the effort to say, call anesthesia and say, listen, I have this patient with XYZ. We would like an anesthesia consult from you. Also, you never have to pay for these, to my knowledge as well. Free, okay? Yeah. So heart and lung disease. So anything with cardio, some of these words are going to be, I'm just going to read through it because you never know. I think if somebody might hear something and think, well, I didn't realize that would be relevant to my birth experience, or I know I have this, but I just didn't make the connection, or it's sometimes people have things that it's like, it's not causing them an active problem. So they kind of don't just recognize that there could be an implication. So some of these might be medically terms. Bear with me.
Let's go, Jen.
Okay. All right.
That's what ChatGPT is for.
That's what, So cardiomyopathy. So one that we sometimes see is hypertrophic cardiomyopathy, which is called HOCM.
Okay.
So that's sometimes younger patients know that they have this. It runs in families. Sometimes they need to get implantable devices, defibrillators if they have, depending on the degree of severity of HOCM. So that would be one of them. Congenital heart disease. So we know more and more a lot of the congenital heart diseases that way back when babies didn't survive. Now a lot of people are living long, normal lives with congenital heart disease that's been repaired as a baby. And so we need to know what is the current status of that, what kind of repair did they have, what is their functional capacity, any notes from the cardiologist, stuff like that. So you'd be surprised when people have it repaired and they feel fine, and they might not think that this is anything that we need to look at closer.
Especially if they had it done as a child. Maybe they just wouldn't even think that would matter in their adulthood.
Right. And it may not, but I'll tell you, what you don't want is someone coming in and reading that you had this thing on your heart, and then we're frantically looking around for records and trying to figure out, is it okay to do this plan versus that plan? Like it would go so much smoother for everybody just to completely understand what your current situation is and have all of our backup plans ready to go before you come into the hospital for delivery at all. Any kind of moderate or severe valve disease. So a lot of people have, like mild mitral valve, mitral valve prolapse or something. Like sometimes you might have a mild form of some of these things that someone told you once, you had a murmur, this or that.
Yes.
May or may not be.
I had a murmur.
There you go. You had a murmur. Lots of people have murmurs. So we'll want to take a closer look at that, see exactly what the severity is. Is this something that we think is going to affect you in any way with all the fluid shifts and things that happen with pregnancy, delivery, and anesthesia? Let's see what else. Pulmonary hypertension, unlikely, but it can happen. Arrhythmias, SVT is pretty common in pregnancy. So if you are one of those people that's had SVT at certain times in your life, maybe you've had any treatment for that. Wolff-Parkinson-White sometimes goes along with SVT. If any of those buzzwords have ever hit your mind, think about getting an anesthesia consult. Coronary artery disease, unlikely with a younger patient population, but we see it every now and then. Anyone who has an implantable pacemaker or AICD, we want to know why and really have that understood well before you come in. Severe respiratory disease, that's kind of vague, but okay. And then the next category is blood clotting abnormalities. So I'll tell you the ones that are on this list. Okay. Because again, common. If your platelets are very low, under 100,000, you've probably been diagnosed with something related to that, seen a hematologist. We want to see those hematology notes, understand it completely. We know this is something that can happen during late pregnancy and delivery. It's kind of different, but if this is something long-standing that in your late second trimester, it would be something to talk to us about, because we may or may not have issues with neuraxial anesthesia with that. Other inherited coagulopathies, von Willebrand's disease, super common. And there's different types of that. So we need to understand most of these patients, the way that the blood clotting changes in pregnancy, where our blood clots easier. This usually doesn't become an issue towards the end of pregnancy, but it's something that needs to be followed. And we may need to do an extra test when you come in if you have that. Factor 11 deficiency. This is something that people are finding out about themselves through all of the genetic testing that's done nowadays when you get pregnant. And so you might have had no idea.
Yeah.
And that's something we definitely need to understand. That's a little more complicated. Hemophilia, most people know if they don't have that.
Yes.
Anticoagulation therapy. So you were on anticoagulation. What were you on again?
It was Lovenox and then heparin for a week before my scheduled delivery.
Okay. So so that's Lovenox and then heparin. Yeah. So some people might stay on Lovenox. The difference between Lovenox and heparin is it has to have been a longer period of time since your last dose. And it also depends on if you're on a treatment dose versus a prophylactic dose. And a lot of times MFMs are doing these like funny in-between doses that we have to think about. And how long do we really need to wait to make it safe in order to get a spinal or epidural? So if it were me, I don't think this doesn't come up as a huge problem usually, but I might want to know if I go into labor before I've transitioned to my heparin.
Yes.
What is the plan? How many hours will it, if you want to be like really understanding, I guess, of what your care is and to know that I have to be off the Lovenox for 24 hours or 12 hours, whatever it is, depending on the dosing. And so if I go into labor, something emergent happens and it hasn't been XYZ time, then would I need general anesthesia for my C-section?
That was actually a major stress for me. And actually, as you're saying all of this, I'm incredibly angry that I was not told that I should have a consult because I think
You've been a great
emotionally,
candidate.
but I should have been, I 100% should have. I guess I was just like trusting that my MFM and my hematologist, that everybody was collaborating and I was just trusting that. But I will say that actually was one of my fears. Was like, well, what if I don't get off the Lovenox in time? Like, how will that affect my delivery?
Right. And what if you could have asked someone that?
I would have felt so much calmer.
Did you listen to that podcast episode that I sent you?
I sure did.
Did you hear when they were discussing the term fawn as it relates to trauma?
I know. And I actually love that term. I instantly
that is Bethany.
It was me. It really was me.
It's a trauma response.
It is a trauma response. Like trying to say like calm when you're just like internalizing this fear in such an intense way. And I think that's where we then store that trauma differently when we hold on to it.
Yeah. And I would say maybe.
Okay.
Because I also completely trusted my providers. But I feel like there is that difference between the fawn trauma response and the just feeling really fully, completely educated and trusting and knowing that you're being taken care of. I'm sure it's a fine line to walk, but
I'm sure.
I definitely thought of you.
I'm sure you did. I thought of myself very much.
Anyway, so
it's also okay to be a fawn.
It's okay to be a fawn. It is, but it's just interesting that they calling it a trauma response. So that means like as long as you're taking care of your trauma and recognizing that it's okay. So that you can still advocate for yourself despite the trauma that's behind it all.
Yes. Yeah.
Okay, back to blood clotting. Jehovah's Witness, if you have a religious reason to refuse blood products, yes, blood transfusions, then that's definitely a discussion to have because some people will, there are different things that they will or will not accept. And having us understand that and make plans for you ahead of time is huge, huge, huge.
Yeah, super important.
And anyone with a very significant bleeding risk, for example, placenta accreta. So if you're going in with knowing you're going to have a big surgery, the management of placenta accreta is very different depending on exactly what your situation is and the opinions of who is going to be taking care of you. So I can't even say like this is the way that it's done. It's so dependent. So that's something to really have a conversation with an anesthesiologist about what type of anesthesia I'm going to be having, where am I going to be having the surgery in the main operating room versus labor and delivery, and that changes things when it comes to where you're going to be recovering and where your partner is going to be. Lots to say about that. Okay, next category, musculoskeletal disease. So again, this is going to be it's all kinds of anesthesia this all affects. But for severe scoliosis, scoliosis is common,
Yes.
but there's different types of severity. So if you have severe scoliosis, and this may be a case where looking at your back is required, or at least looking at imaging. And so this is when I have these types of consults, I often want to see their most recent MRI or any imaging that they have recently. Sometimes I've felt the need to even say you need to go obtain it if you don't have it. Some people don't have that lying around. It's not in our system. And that will really create a lot less chaos when we're making our decisions and we don't have the imaging available or we're looking for it ourselves. So just walking in really prepared for that. Going along with that, oftentimes people with scoliosis, they may have had extensive back surgery. So if you have fusions, rods, et cetera, we need to determine how risky we think neuraxial anesthesia would be, if we think you'd have to do general anesthesia, et cetera. Severe inflammatory arthritis, like rheumatoid arthritis or ankylosing spondylitis. Neural tube defects, so anyone with spina bifida or tethered cord, we need to worry about with tethered cord where the spinal cord actually ends. So that would require some imaging. And other congenital bone diseases like osteogenesis imperfecta or achondroplasia are all good reasons to have an anesthesia consult.
Can we add one more on there?
Sure.
If you just want to be incredibly knowledgeable of how the procedure's going to go and you want to meet your anesthesiologist.
Well, I'm not there yet.
Oh, sorry.
We're still on when anesthesiologists specifically ask the OBs to send patients to them.
Got it.
Like in the sense that if somebody shows up to me with, let me pick one, hemophilia.
Okay.
And they come into the hospital and they have been seen by the obstetrician for weeks and months, and no one told us about this patient. And they show up, then we are mad.
I'm sure.
Because we should have known about this patient and spoken to this patient and had time to formulate our plan ahead of time. So this is those kinds of situations. That doesn't mean these are the only reasons you can request one, but this is when we actually will be upset should we have not gotten one.
Fair.
Okay. Neurologic, next category. So anything, brain tumors, any vascular malformations in the brain, like an AVM or an aneurysm, if you are aware of that, if you got a Prenuvo MRI and are now aware of something that they found and isn't causing you any problems, we need to know about it. Arnold-Chiari malformation, we've gotten emails about this.
What is that again, please?
Okay. It's an abnormality of the skull base, and it's where this is what I know of it, and the brain is kind of sagging low. And so it's like, what a brain herniation is.
Yes.
Yeah, so it's not, it's the formation makes it such that you're kind of nearing that point. And a lot of times people, even in teenage years, have a lot of headaches, and then they go get a CT scan or an MRI, and they find this Arnold-Chiari malformation. There's surgeries that you can do to release kind of the pressure on the brain. And so this is common. I will say most of the time it's fine. We go by symptoms. What are their current symptoms and what is their status of repair to decide on the safety of spinals, epidurals, general anesthesia, all of which come with different small risks. If you need to have a C-section, even if you're planning a vaginal birth, it's good to have just an understanding of what is your current status of the malformation at that time, basically.
Got it. Okay.
But common in young women. A lot of these things are common in young women, which I think is why they're specifically pulled out, even though they're unusual kind of, right? But MS, myasthenia gravis, spinal cord injury, I think those are all kind of obvious. And then the next category, my last category, has to do with anesthesia complications specifically. So do you know what malignant hyperthermia is, MH?
I do. It's when you're, don't tell me to give you the definition, but I have heard it before.
Yeah. So it's basically usually hereditary thing where the general anesthesia gases and one of our general anesthesia medications, succinylcholine, can
pushes your temperature, body
create
temperature.
this condition called malignant hyperthermia, which is very, very, very dangerous and potentially even deadly. And so most people, this is a question that we ask anyone usually who's going in for surgery. Do you or your family member have a history of MH? Or we'd kind of say problems with anesthesia and go from there. And we definitely have had patients who either have a personal or family history, and we will actually change out our anesthesia machines. We have to clean them out to get rid of any of the gas. and use something that would not trigger MH. And it's a whole, you have to set up an entire OR and leave it ready for that patient in case they need it.
Wow.
So that's a big deal. What else?
So that's why too, and I thought I liked when I listened to the birth trauma podcast that they talked about, even if your plan isn't to have a C-section and your plan is to have, or your goal, is to have vaginal, if you have any of these conditions, you should still seek out having a conversation with anesthesia because you don't know how the end mode will be. And that preparation aspect of what you're trying to do on your end as an anesthesiologist is so important, no matter what that plan going in is.
Everybody would rather have an OR ready for you if you have something like this and never use it.
Right. And on the patient side too.
The vice versa.
Great. Even if the anesthesiologist comes in and sees you just to make that like introduction, doesn't that feel better in that process of you were successful with your vaginal delivery? Amazing. It had a transition to a C-section. At least you're not seeing that anesthesiologist for the first time.
Yeah, for sure. Other things that we worry about specifically with anesthesia are anything with the airway.
Right.
So if you've had surgery before and you were told that it was difficult to put a breathing tube in, I hope that they told you, please tell everybody anytime you go in for a subsequent surgery. But this would be same with anytime you're going in for a baby, because you just never know if that's going to end up in requiring anesthesia. We need to know that. We need to have our special equipment ready. You know, we kind of do anyway, but just having that on alert is very important. Anyone with surgery to the trachea or the larynx, anyone with radiation to the neck. So that might be thyroid cancer if you've been treated for something like that. Just important for us to know and explain to you what we are going to do to be prepared for that in case you need to be put to sleep under general anesthesia. And so that's the list of things that we definitely, you got to come see us if you have these issues. But we know that a lot of times it's patients who I feel like they have so many lingering questions and concerns, and they want to talk through them before they get to the hospital, right? Especially if you're going in labor or you're going in anxious and nervous. It's just so nice to get a lot of those questions ahead of time. And I feel like a lot of times these anesthesia questions get directed towards the OBs because that's who they're seeing in their appointments. Yeah. But let's just say it's better if we can get a direct connection, to talk to someone from the anesthesia side. So any history of birth trauma, I think, is perfectly fine to request and lay out your specific what happened to you previously and ask any questions about, so that you can maybe understand a little bit more what happened and what are we going to do to prevent it.
And I think going in knowing that the situation is going to be handled in a different manner. And if you're having that consult, you can create that plan so that whatever caused that trauma, you're doing everything in your power as the anesthesiologist, and the patient is being more knowledgeable to say, these are the changes that would make me feel so much better, and what are those changes that you're going to do to help me through it.
And, you know, in your case, even if it's a history of a loss, if you wanted to say, this is how I want to be talked to about it, or this is how I don't want to have to repeat myself over and over again about it, this is why I'm going to be very anxious. And then it can kind of flow into, I am going to be very anxious because of this history, and what are my options for a treatment of anxiety?
Totally. That's actually going to be one of my questions to you. If someone is coming to you and they're not falling under one of these categories of the list that the OB sent them, is your first question to them like, why do you want to have this consult with me, so that you can kind of understand?
Yes.
Yes.
For sure. Yeah. And then oftentimes there's more to it that you get to because they're worried about something. And then let's say I talk through that something and then they say, well, okay, like, thank you. I understand. I have like this history of anxiety. And I also want to know, you know, have you been taking anything for anxiety during the pregnancy, or were you taking anything for anxiety outside of pregnancy? And then I can go into discussing management options depending on how things go, of which there's a few, you know, and what are your priorities, talking about your priorities. I love that word. They use it also in the podcast I was talking about, talking about plans, preferences, but the word priority I really like, because it's, okay, my priority is to be awake versus my priority is to not be anxious. So if you give me anxiety medicine and I get sleepy, that's kind of okay. Versus my priority is to be really present. And so then the treatment might differ, right? Or my priority is not to feel pain. I'm terrified of pain at all costs. I don't want to feel pain. It's okay if I end up being sleepy. Like whatever it is, you kind of like lay out all the possibilities and prioritize to help you
Make a plan. Yeah. Oh my God, I love that too.
Don't you love that?
I really do.
Hold on, I have a couple more here. If you are going to request general anesthesia, great reason to talk that through ahead of time.
Yes.
And why you want general anesthesia. Ask all your questions. What really are the risks of general anesthesia? We can get to know you. If we think you personally are at higher or lower risk for general anesthesia, and move through the conversation that way.
Also, too, because with general anesthesia, obviously the partner is not present in the OR during that.
Which you may not know if you didn't talk to anesthesia.
Well, I was just going to say, do you normally have the consult with just the patient, or do you recommend having it with the patient and the partner?
On the phone, they've always been just with the patient. But when we used to do them in person, and like we still do it, I just haven't recently. I think sometimes the partner would come, and that would be a choice for you to make if you would rather have your partner there, but they certainly can be if you want them to be. And then this is what our listener had emailed. She had what to me seems like an anesthesia complication. Obviously, I don't know exactly what happened, but it seems like she had a high block, a high spinal, and she needed to be put to sleep, intubated because of that high block, that high spinal, for her emergency C-section. And so to me, that's a major complication. And not only understanding for her what exactly happened there. Why did this happen to me? Is there anything about me? I doubt it, but good to know.
Oh, for sure.
That makes me at any kind of risk for this very, very rare complication to happen again. What are we going to do next time? And she was even talking about planning future pregnancies. Still early postpartum, but you start thinking about that already. Of course, I think a lot of us do. If we're planning on having another, like the second you give birth, you're like, oh, what's the next one going to be like? So even calling and saying, look, I'm thinking about getting pregnant again. I want to be pregnant again, but this is holding me back. I'm worried because I had this anesthesia complication. So therefore, the best person to talk that through with is an anesthesiologist.
It actually brings something up. So could you request to have a consult before even getting pregnant again if you had a situation occur that caused trauma and you knew you had to process that before you could even think about conceiving again?
Yeah, absolutely. I mean, do I think that that's common? No, but I think maybe we should do it more.
Yeah.
And particularly if you are calling an anesthesia department where this complication occurred, they very much owe that to you to give you the answers that you need to help you feel more comfortable going into another pregnancy. I think, we don't see it, but I'm sure.
But I think it's a really good thing to bring up. I mean, knowing that people don't even know that this consult is available and thinking, I wouldn't even have had it on my radar to be like, maybe I should have this consult before I even think about conceiving again if I know this is a huge barrier to being pregnant again.
Yeah, anytime. Other related to anesthesia complications, if you had a failed spinal or epidural. Now, some people, their epidural didn't really work in labor. They had to get a new one. Everything was fine. Not necessarily, you don't need to call ahead and discuss that, but you could. Regardless, you need to bring that up when you talk to your anesthesiologist before whatever procedure you're getting, before your C-section, before getting another epidural. In fact, let's say you're trying for a VBAC, so you know you're at higher risk for ending up with a C-section, and you had trouble with your epidural previously, and you're thinking, I'm just going to avoid it this time because I don't fully understand what happened, and I don't want to have to go through what I went through before. And then you might get there, and the nurses or the OBs might be recommending an epidural so that you have an epidural in place in case you need to go for a C-section. And then you might be confused and wait, you haven't really thought through this yet. You thought, I'm just going to avoid it. And now it's just kind of getting any of those things out ahead of time. And definitely with, any failed neuraxial that ended up causing you pain during a C-section or required general anesthesia during a C-section, allowing us to talk through that with you. How are we going to prevent this in the future? I think those are all great reasons to talk to somebody.
I mean, I think the point of a consult is to get in front of a fear factor that you have. It's to break that barrier down. And that's why I'm so glad you are talking about it, because I think that maybe a lot of our audience base, like there has been fear. They're coming to us for a reason. Mm-hmm. So you just talking about this, like, I so wish that I had one, and I could not. Like, it will be something I recommend to every one of my clients. No matter the mode, you must put this on your radar.
Yeah, I love it.
I love it too.
Just a couple more examples. So if your spinal or epidural was very hard to place, there are people who say it took forever, which is all kind of relative in that time, but it took a long time. They had to get a different person come in. They had to pull out the ultrasound. Any kind of situation where it was very difficult, we want to be able to talk through that situation for you. What is it? You know, is it potentially, do you have undiagnosed scoliosis? Is there someone you can see from the orthopedic world to give us a sense for why this must have been so difficult? We can maybe recommend getting the epidural placed when you're not in labor, if it's like easier to move, better positioning. Could you have learned more about the positioning ahead of time to prevent that kind of issue? Or is this something really anatomically where it may happen again and we need to talk about general anesthesia a little bit more than we maybe would with somebody else? That's another great reason. Anyone who's had a spinal headache, cerebral puncture headache, talking through what kind was it? Was it with a spinal needle? Was it with an epidural needle? How long did it last for you? How is it managed? So you could talk through your risks of that happening again. What are we going to do again to prevent that next time around? Anything else?
Oh, no, I can't actually.
You can't think of any more? I've been too my list is too exhaustive.
No, it's not that. No, it's anytime you have these like deep dive topics, I feel like I just become like a student in the recording studio, because I'm like taking it in. I'm trying to process it too, because a lot of these things I didn't know. You're teaching me right now. You're obviously teaching our audience. But I mean, I think I just always think of things more of like in the emotional aspect. And so for me, like, yes, there's like the factual, but there's such an emotional component to like, I wanted to tell my story so that like the team understood why I was the way I was in that OR. Like, it just made me feel like I wasn't crazy, that there was a reason for it. I don't think you have to have a huge reason. It can differ, but it just made me feel safe that, I don't know.
Yeah.
Do you know what I'm getting at? Like, I just feel like in a consultation, I think that with every doctor I saw, telling my story was also kind of therapeutic for me, but it also allowed me to know that they didn't think I was like creating something unnecessarily. And I don't know why. I feel like maybe as women, I know I'm a very sensitive person, but that we like, oh, I'm creating this into something more than it needs to be.
Yeah. You also don't want to have to tell it to every single person that walks into your room, though.
Totally.
But you, I assume, probably would have liked everybody to know so that they don't make some kind of comment that maybe would make you feel not so great, potentially.
Yeah.
With an anesthesia consult, whichever way, whether it's in person or via the phone, we then write a note that goes into your chart. You may not be speaking to the anesthesiologist who actually ends up taking care of you, which is something to note because we all don't practice exactly the same way. But it's there for the anesthesiologist then go back and look and read.
Right.
And then probably reconfirm with you, this is what I read.
Right.
Like, is this right? This is what you discussed. And if they have any differing opinions, I see here that you felt that whatever, treating your anxiety with this way is the choice that you would make. Let me just tell you about the other thing that I like to do and see if you might like that idea. So things can change.
Right.
But having that already written there. And so in your scenario, if you went through something that's very traumatic, not necessarily going to affect you medically in this new pregnancy, but you could say, my hope would be that everyone would be aware of this story so that you could even say, like, because I might be acting a little different than the person I truly am, because this is so emotionally overwhelming because of what I went through. And so if you could just pass that on.
Right. Well, that's why I brought up like the crazy factors. Like, no one wants to feel that way. I also think it is really important because I do think that the nurses were very mindful of the word choices that they were saying to me in the OR. I think that's why it's important as a patient to speak up as well, because like I didn't know how it was going to affect my bonding initially. And I think that it's important for, like, they eased into showing me the baby. Like, I felt like they were like, she's probably going to be really overwhelmed. And I was. It was like immediately, like we talk about, some people like the baby to be brought right over, cheek to cheek, touch right away. For some people, it's like, I need a second.
Yeah.
And that's okay.
And if you can predict any of that at all, it seems funny to tell the anesthesiologist that, but it's not, because we are the ones that are really with you and facilitating a lot of that.
Totally.
So if you could even say that. And by the way, I'm worried about bonding.
Yes.
This is what I think, whether it's, skin to skin would really help me, or I might need a minute, whatever it is, explaining that, they'll just put that in the note. And then when the time comes, more and more people that are aware of how best to help you in that moment and what your fears are. That was my last one, was fears. If there is something that you just are really afraid of, doesn't matter what it is. People are scared of spinals and epidurals for various reasons.
Yes.
It could just be, I'm just really afraid that placing it is going to hurt. That could be a fear. Talk me through, how bad do these really hurt for most people? What can I do to make it hurt less? And, we're going to numb your skin. We'll give you more numbing. We're going to really optimize your positioning before we even start. We're going to let you know when you're, those types of things, if that's your fear. So whatever the fear is.
My fear was moving. And like right now, I've had like an ongoing cough for so damn long.
Yeah.
But like, think about that. If you're going in and you're like, I have this chronic cough going on right now, you're like, okay, I want to make sure I don't cough when you're, think about it, or you sneeze or whatever. Like, I was so afraid. I was like, I will be a statue. I will not move a single inch, but that was a huge fear for me, is that I would move and I would somehow disrupt placement and just, I don't know.
Yeah. It's a common fear. And I always try to downplay that. It's like, the movement is so common. I'm not saying that it can't affect things, but I mean, when you're doing a spinal or an epidural with someone who's in labor, or you're doing a C-section on someone who's vomiting the entire time, it's just not as big of a concern as a lot of patients think it might be.
But that's why
are you
have
talking
to
about
say it.
During the spinal you were worried about moving, or just during the whole thing? You just were like frozen?
No, during the spinal, I was terrified. What if I move, And that's why I love the pillow trick. For some reason, like having the pillow in front of me gave me that feeling of comfort, that I was like holding something that was also keeping me still. Yeah. And it was more comfortable too.
Yeah, and just a movement, like a lot of people jump with the local, with the skin, but it's like this like tiny flimsy needle that there's just like very little harm that can be done, even if you like really jumped at that moment.
I think some people are afraid of needles. When they think of a needle, they're thinking of like a long, intense, hard needle.
But like when we first numb the skin, it's like a little baby, nothing needle, super thin, so it hurts less ideally. But the reason it hurts is not because of the needle. The needle's so small. It's because the actual local anesthetic burns. It's just the way that it is. Yeah. But yeah, like talking through any of those things, if they're really keeping you up at night, and if taking some of it off your plate makes you come in feeling more calm, I feel like it's all a good reason. So yeah, so I wanted people to know that you won't necessarily talk to the person who's taking care of you. So it's not 100% in stone, but a lot of the work is done ahead of time. And if there's any advanced planning, the benefit is a few weeks before you're actually going to deliver, so that you can make any changes, see any specialists. Sometimes I do things because I know what other people, like let's say I'm not taking care of this person, I know what other people would want to see in order to proceed in a certain way. And so sometimes we can help with that, get a clearance note from whatever, get your last echo from your cardiologist, make sure that we have it in our system. Yeah. Any of those little things that you can kind of wrap up before you come in for delivery, aside from just getting your questions answered.
Right. No, I think that's so wise. I like you saying the end of the second trimester, beginning of the third trimester. So then that when you're nearing that point, you're focusing on getting things ready for the baby, doing things for yourself at home, rather than worrying that you have these like check box lists that you haven't gotten to yet. Yeah. Have you been having more consults?
I haven't gotten very many recently. I'm kind of sad about it.
Maybe after this episode, you may be getting a lot more, Jen.
Because I love being able to talk to people ahead of time. And I do feel like people are so different, in certain scenarios. When you're at home on your couch on a phone call versus coming in a very anxiety-inducing situation, maybe you're having to have your C-section a couple days earlier than you had planned because something happened, or if you're in pain. I mean, pain just really changes
someone's personality so much. Oh, of course.
I just see that all the time with an epidural. It's just the funniest thing that people, whatever it is, they just change when they get comfortable.
Of course.
And
well, I feel like you can go,
so much
you go from an
clearer.
internal state, right, to an external state where you're like looking around in a different way. You're like, oh, hi, Dr. Jen.
Because you're coping. That's what it is. It's like with anxiety or with pain. When you're coping so hard, it's hard to communicate and it's hard to take in information.
Right.
So being able to do that ahead of time, I just highly recommend it. I think a lot of our listeners who ended up writing to us later and their next experience was really good. A lot of them did say they spoke to their anesthesia team beforehand. They made a plan.
Yes.
Plan when is planned.
Yeah.
In the C-section world.
Yes. So please request a consult. I think that's the biggest takeaway from this whole conversation is it's possible. It should be covered by your insurance. You're not getting paid extra to do it.
Yeah. It's probably just part of the
umbrella.
What the hospital provides.
Nice.
Yeah.
Nice. I love it. Thank you so much. Thank you for giving us that super valuable information.
I hope that this inspires someone to get an anesthesia consult. Please let me know if you have.
I almost want to have a post-anesthesia consult.
Yeah, do it anytime, pre-post.
Yeah.
But certainly if you're having another baby after an experience that was scary or you have any specific fears and worries, this is what we're here for.
Yeah.
And please continue to follow us on Instagram.
Yes.
DM us.
Yeah, we love the DMs.
The C-section experience is our handle. And email us, hi@csxpodcast.com. We love to hear from you. Give us new ideas. This is what happens. You send us an email and we get an idea. And this is how we can help other people and get the message out. So thank you so much for watching or listening.
Bye.
Bye. We had so much fun recording this episode, and we hope you enjoyed it. We are also now on YouTube, so please head over there and subscribe to our channel to watch our full episodes.
We love having all of you as a part of our community. Please take a moment to rate, review, and follow the C-section experience wherever you listen. It really helps us grow and reach more amazing listeners just like you. Bye.